Okay, hello everyone. Good evening here from the US anyways. Welcome to another session of the Virtual Global Spine Conference. We are absolutely thrilled and honored today to have with us Dr. Allan Levi as our guest speaker. Dr. Levi is the professor of neurosurgery and chairman of the Department of Neurosurgery at the University of Miami Miller School of Medicine in Miami, Florida. Dr. Levi really needs no introduction. He's one of the really global leaders in neurosurgery and spine surgery in particular. He has been educating and training residents and fellows for many years. He runs the annual Goodman Boards Review course here in the U.S. Very well published on spinal cord and peripheral nerve surgery, pathology, new techniques, and of course, they have a lot of very innovative spinal cord injury programs in Miami, including the Cure Paralysis Project. Without further ado, Dr. Levi, thank you so much for joining us today and speaking to us on a very interesting and important topics in neurosurgery and spine surgery.
Very cool. Thank you, Ali, for that introduction and invitation. And, Ali and I have known each other for at least a decade or more, and he's been also integral in helping us with the Goodman course, and we always appreciate that. I'm going to talk about intradural spinal pathology, and you'll see that it's a pretty wide topic. We're going to go over some of the pathologies that we see in these problems and try to develop, you'll see a set of rules, and rules are also meant to be broken, but it's because of the sort of rarity of some of these things, it's good to have some rules in the back of your mind to deal with these problems. So, and for me, in particular, in my practice, it's something I really like to do, and have been fortunate enough over the last almost 30 years to get a lot of referrals of these types of problems. So again, that's why I put this talk together a few years ago for our faculty and residents. So these are my non-relevant disclosures. We're going to talk a little bit about philosophy before we get into the details of the talk. And, it's interesting in neurosurgery, the vast majority of surgery that's done is spine surgery. It's certainly in the United States. And if you look at CPT codes for surgery, about 65% is spine and about 35% is cranial. So as a neurosurgeon, you clearly need to know about spine surgery and all of the different spine pathologies. I always find it interesting that in neurosurgery, there's this general feeling that, the cranial surgery is the very refined part of neurosurgery, and that spine surgery is very kind of blue collar, drilling and not eloquent. I'm going to start my conversation by saying that that's not true at all. And I love showing this diagram. Comparing the anatomy of the brain and the anatomy of the spinal cord. And the picture on the left is, from the Spetzler-Martin grading system, showing the eloquent parts of the brain, the motor and sensory, the speech, visual cortex. But I would argue with you that in the spine, and particularly in the spinal cord, everything is eloquent. And while you can take out a tumor in the frontal lobe and injure a few axons along the way, not a big deal. But if you injure a single axon in the spinal cord, it's a big deal. And so I would argue that, removing tumors from the spinal cord, no matter where they are, is a much more difficult task, and the precision required is very high. So my rule number one that I want to issue is that there are no silent areas in the spinal cord, while there is silent areas in the brain. The other philosophical point that I wanted to make is about medical legal aspects of spinal surgery. So in Britain, and this is, I'm going to talk about, and since this is an international conference, it's good to pull out some British data. In Britain, actually, it's the opposite. 65% of surgery done is cranial, and only 35% is spine. But when you look at the medical legal claims in Britain, and they're much less than the US, the majority of medical legal claims are in spine surgery. And that's very complex about why that is. But in part, I think it has to do with expectations. I think people who have cranial surgery, they come out alive and they're happy. In spine surgery, people expect perfection. And if you look at this particular paper, it talks about the reasons why people get sued after spine surgery. And I don't have to read all of this, but misdiagnosis, delayed treatment, faulty surgical technique is definitely a big reason why people do get sued. This is American data. And again, it kind of shows the same thing. This is data from the UCLA group, and a very honest portrayal of that department's medical legal claims over a period of time. And if you look at it, again, most of the claims are spinal surgery claims. So again, speaks to the importance of doing good and safe surgery in the spine. So getting to the main topic, which is intradural spinal pathology, I'm a big stickler for numbers, and including my own numbers. And this is something, if you're interested in that area, it takes time to develop a practice and a referral base. And that's basically what this graph shows. When we're talking about intradural pathology, you have to distinguish between intradural extramedullary and intradural intramedullary. Typical lesions that are intradural extramedullary are listed to the left, and the intramedullary pathologies are listed to the right. And we're going to go over some of this, not all of it, but typical tumors, intradural extramedullary, schwannomas and meningiomas. And typical intradural intramedullary are things like ependymomas, hemangioblastomas, astrocytomas. And then there's a list of some of the other less common pathologies. From a radiologic point of view, and this picture in the middle is very instructive in terms of distinguishing how these lesions look. And it doesn't matter if it's an MRI or a myelo-CT, how the CSF is layered around the spinal cord. It helps distinguish between those two pathologies. So in an intradural extramedullary tumor, there's often a cap of CSF that you see, and in an intradural intramedullary tumor, the cord is expanded and it's more of a fine stripe of CSF around the lesion. One of the ways to distinguish between those two pathologies. And then this is just my own personal series of cases over the last 27, 28 years, showing what percentage are intradural extramedullary, how much are intradural intramedullary. And, what I wanted to emphasize with this slide is that they're relatively uncommon. So when I look at during my training, and I trained in places that are very busy, very large academic center. I did my residency in Toronto, where we were operating every day, and I did my fellowship at the Barrows a long time ago. And you can see, like, in terms of intradural spinal cases, as a resident, I literally had only 28 cases over 7 years. And as a fellow, I only did 1 case over that period of time. So, in our academic center, where everybody's very subspecialized, and even within spine, we're subspecialized, it takes a while and subspecialization to develop, an expertise or an experience in a particular area. So we're gonna start talking initially about intradural extramedullary tumors. And my rule number 2, we talked about rule number 1, which is there are no everything is eloquent in the spinal cord. Rule number 2 is that in intradural extramedullary surgery, there is no retractures or retraction of the spinal cord permitted. And again, that's a relative rule. In some cases, you do have to retract a little bit to be able to get at a lesion. But in general, when we remove tumors, we're always working within the tumor and then basically retracting on the tumor, not retracting on the spinal cord. So this is a tumor at the cranial cervical junction. It's ventrolateral. You can remove it without retracting on the spinal cord. Cutting the dentate ligament is critical, and you can work intralesionally to remove this meningioma. And one of the decision points is this something that needs a laminectomy? Does doing a facetectomy help you? Do you need to do a far lateral? And I would argue that in the vast majority of cases, you can remove them just using a laminectomy, but using techniques to be able to internally debulk the tumor and bring it away from the spinal cord. I think most of the intradural extramedullary lesions, whether they're meningiomas or schwannomas, are fairly straightforward if they're dorsal. Where it becomes a little bit more complicated is if they're ventral or ventrolateral. And again, knowing the anatomy of the dentate ligament, the ventral dorsal rootlets, in the upper cervical spine, the spinal accessory nerve, and how to mobilize them to get access to the tumor is critical. Another rule that I would tell you is that almost all, and rules again are meant to be broken, but I want to say that 99% of tumors can be removed from a simple posterior laminectomy approach. Even if you see ventral tumors and you have a desire, well, maybe I should do a corpectomy and remove it via that approach, I would resist that approach at any cost, and I'll explain in a little why that can become problematic. And the best way to show how it can be problematic is talk about this particular case, which was referred to us from one of the islands. But it was a patient who was 38 years old. He had progressive quadriparesis over a period of 3 years, including bowel, bladder urgency, and stress incontinence. And you can see this lesion, which is very ventral, and most likely represents a schwannoma, and is compressing the cord at the C2 to C4 level. The decision was made to go through a ventral approach to remove it, meaning a partial corpectomy of C2 and C3, opening the dura from the front and resecting the tumor. The patient is a little obese and had a history of hypertension and diabetes. And that was what was done in the islands. And, unfortunately, and again, this was the patient's preoperative exam when we saw him. But unfortunately, what happened is that after the surgery, after this corpectomy surgery, the patient woke up quadriplegic, was on a ventilator for quite some time, but fortunately, recovered over a period of 6 months and did relatively well for several years, but then represented with progressive quadriparesis. This is what the patient's neurological exam looked like when we saw them. And this is what their imaging showed. So while the vast majority of the tumor was removed through this ventral approach with that complication, you can see now that the patient has a ventral cord herniation from opening of the dura at that level, and has become now more and progressively quadriparetic 2 year, and he had this known ventral cord herniation, but the herniation progressed over a period of 2 years. So this is what it looked like 2 years before we saw him. This is what it looked like when we actually saw the patient. And you can see that the cord has edema in it, and then it is herniated through this ventral slit in the dura. And that's a higher power view of what it looks like. And so the question is it better to go through the front to take care of it, better to go through the back? And as with most of these ventral cord herniations, whether it's spontaneous or iatrogenic, the best thing to do is to go from the back. This is the axial images at those levels, and confirming the ventral cord herniation. This is what the CT scan looked like. You can see that he had a fusion done from the front after resecting the tumor from the front, no CSF or anything from the front. And so these are some intraoperative images. You can see that the cord is very thinned. This is the dentate ligament. These are some intraoperative images looking at the front of the cord, cutting the dentate ligament, trying to get to that area where the cord is herniated, and then eventually working around it and eventually pulling the cord up from where the ventral hernia was. And once that's done and it's freed up, if you just stop there, clearly the hernia is the cord is gonna go back into the defect. So the next step is, fashioning a graft to go in front of the cord and prevent it from reherniating. You can see how thin the cord is at that level. Again, from the intrinsic changes that resulted from the ventral cord hernia. And this is with the graft sewed in. And this is what the post-op MRI looks like. So the cord's back in place. You can see the ventral graft. And the patient did well, woke up well. And we were all, clapping and feeling very proud of ourselves. This is, again, the axial images, and you can see that a ventral sling keeping the cord away from it. But he came back at about 3 months, and this is our laminectomy, and you can see he's developed a post-laminectomy kyphosis, interestingly, at a level where we never even did a laminectomy. But clearly, probably with dissecting the paraspinal musculature and him having a prior fusion, he developed a kyphotic deformity, which then required an anterior-posterior approach to realign the spine. I said that, you should never consider going from the front, and I would say that that's, a rule, but occasionally needs to be broken. This is a case of ours, or of mine, where the patient had a ventral schwannoma that arose from the right side and was clearly very ventral. And we felt, and this is the cord being pushed dorsally. In this particular case, we felt like going from the back would be pretty difficult, and a lot of it would be blind. So we did a lateral approach towards the tumor and used image guidance to sort of help us understand the lateral anatomy. You can see the vertebral artery here. And so you have to navigate through the posterior triangle, do sort of a lateral laminectomy, facetectomy, and a transdural approach to be able to gain access to the tumor. One of the things that a real bugaboo of mine, and I see it a lot, is, patients who undergo a laminectomy to remove a simple intradural extramedullary tumor who end up having an instrumented fusion afterwards. And doing a laminectomy alone for removing a tumor doesn't mean that you have to do a fusion. But we'll talk a little bit about when you might need to do a fusion a priori. But my general plan is, unless it's absolutely necessary, meaning you removed a total facet or total facet at the cervical thoracic junction, I try not to fuse them and tell them, you may need something done, but let's just wait and see how you do. And I would tell you the vast majority of patients get away without needing. And so this is a paper we published, actually just came out a few months ago, specifically looking at predictors of instability after resection of schwannomas throughout the spine. And you can certainly read the paper, but the punchline is that with this premise of not fusing most people unless absolutely necessary, only 1 in 6 required a fusion a priori, and that of the 122 patients that were analyzed with intradural extramedullary tumors, if you sort of take a facet-sparing approach, that only a very small percentage ended up needing a fusion in a delayed fashion. So it is very reasonable not to fuse someone a priori simply by doing a laminectomy for removing an intradural or intramedullary tumor. And again, I'm not going to go over the details, but all of the details can be seen in that paper, trying to figure out which patients needed it a priori, which ones who failed, was there anything that was predictive. And even in the cases like this with the patient with a foraminal tumor, and patients with a significant facet resection, you can get away a lot of times without doing a fusion. So the next thing, again, is something that's a little bit unusual, but I wanted to speak about, which is a intradural procedure, and it's something that's relatively uncommon, but we probably see 1 or 2 a year, which are these cysts that develop at the craniocervical junction that happen in the elderly patient. And, this is, someone who comes with a myelopathy. They
Dr.
have.
Levy, sorry for
Yeah.
interrupting. I apologize. Just real quick, on the prior point, which is, I think I couldn't agree more. I mean, it's absolutely essential. I think even, in my early days or even during training, we felt that, you did a C1, C2 LAMI for a neurofibroma, you had to do a C1, C2 fusion. I think we were definitely probably overfusing those cases in which we didn't need to. And that's one thing I'm also a very, very big fan of, and I learned it from you and others. What do you think, though? I think the one area that I'm a big advocate of concurrent fusion is for the intramedullary lesions at the cervical thoracic junction, like a C7, T1 ependymoma. I think I've seen maybe a couple of failures, and I've realized that the intramedullary lesions at the junction cause a lot of weakness and decreased innervation to the extensor paraspinal muscles, and those are more likely to develop a deformity, and the revision is harder. Do you notice that, or did you see that in your own series, intramedullary lesions at the cervical thoracic junction? That's probably the one set of patients where I just feel better fusing up front, but I may be wrong.
Yeah, I mean, and I'll show you, we've done about, well, I've done about 150 cases, obviously a bunch of span the cervical thoracic junction. I don't have it in my sort of plan to say, okay, we're going to fuse you up front. What are the upsides and downsides of fusion? I mean, certainly the upside will be you don't have to do a revision and, yeah, I get you sleep better at night from that perspective. What the downsides are, and doing a revision is always harder than doing it up front. The downsides of a fusion are that, you create a big dead space. If there's CSF leak, it can be problematic. Imaging becomes more difficult after, if you're looking to see a small residual. So to answer your question, I don't, but I tell every patient, you know what, we may not get away with it, and you might have to come back at some time. The other big thing is laminoplasty as opposed to laminectomy infusion helpful? And I'm not sure about that either. I've done laminoplasties in people who have then come back with issues with sinking of the laminoplasty. So I typically, certainly in the adult, don't just do a laminectomy and not a laminoplasty. But some people have argued, and I believe Zia is one of them, that you should do laminoplasties in these patients to reduce post-laminectomy deformity. But I generally don't do that, I would say. So the
Perfect.
next
Thank you for
topic,
that.
no worries. Next topic is these retro-odontoid cysts in the elderly. Tough problem, because if you take the approach of doing this, like particular case, endoscopic, transnasal, and resecting the dens and getting to it through that approach, you're often looking at a fusion as well in those patients because of the amount of bone that you have to remove to get to these lesions. And that's a lot in a 70 or 80 year old patient. And, I've definitely seen some of these cases that have not gone well for medical reasons, with an excellent cyst resection, but, patients just don't tolerate that big a surgery when you're that old. So because of that, and because of seeing quite a few of these patients, and because the operative approaches in the elderly can be quite, have a quite a high complication rate, we just started to think of what other ways can we do this. And this is the CPPD that has been described, and we're here. CPPD stands for calcium pyrophosphate deposition, and Dr. Menezes of Iowa described it, and these are usually older patients. He has a more recent paper in 2008 that has 21 patients. But again, because of the degree of surgery, can be pretty morbid. And so, we describe this transdural approach to these retro-odontoid cysts, which are typically at the C1 area. And if you look at this area, there's quite a bit of room on the side of the spinal cord. And this is an intraoperative image showing C1, C2, the lateral spinal cord, the C1 and C2 rootlets. The vertebral artery is up this way. And you can see that you can work through these rootlets to get to these retro-odontoid cysts, especially if they're soft and asymmetric. And so this is an example of an 81-year-old man, I should say, with numbness, dexterity issues, gait instability, has this large retro-odontoid cyst that's asymmetric to one side. Do you go to this way, or can you go through a posterior approach and go transdural to resect the cyst. And this is showing the pre and the post-op imaging studies. In this particular patient, end up getting a fusion, but there's quite a few in our series that just had a cyst removal alone. And again, not very morbid type of procedure. This is another patient with myelopathy and occipital pain and a left-sided cyst and severe compression.
Dura is open in a paramedian fashion. The arachnoid is open sharply with scissors. The dentate ligament is then incised, and we are now cutting into the cyst with yellow-orange fluid emanating. We see the rootlets. The rootlets at C2 are sectioned so that we can enter the cyst. We're bipolaring the capsule so that will facilitate pulling it and cutting it and bringing it into the field. There is no retraction on the spinal cord. We're using micro scissors, again, to deliver additional material. We placed a Woodson underneath the cord, again, to bring large amounts of necrotic material.
So that's just basically showing the surgical technique, and here looking at some pre and post-operative films. And I would tell you, I mean, this is an 89-year-old who presented with cervical myelopathy. For them to tolerate a transoral or even an endonasal endoscopic approach to remove that cyst, that can be quite morbid and often requires a fusion because of that removal. And in this case, you can see in this particular patient, we didn't even do a fusion, and you can see the difference between pre and post-op in terms of decompressing the ventral cord. Again, a good option in a certain number of patients with these problems. And the pathology is usually soft, so you can get a lot out without, drilling and the like. And this was a older paper where we published 6 patients. We're up to about 12 now through that approach. So low morbidity, feasible in the elderly. Many don't require fusions. We published the paper, and again, one of the great things about publishing things, people and patients can look out for you and see if you have an expertise. This was an email that I got of a referral online from the grandson of a patient who had this problem. And he wrote in the email, "I found your name researching geriatric neurosurgery." So it's nice to be known as a specialist in geriatric neurosurgery. So the next.
Levy, sorry to interrupt again. That's a really neat case. Did you have to suture the ventral dura or put a patch like you or what?
No,
Not
it's
at all,
a
huh?
great question, because everything's stuck. So you don't have to do any of that. You just bipolar it, and everything's matted down. So
Got it.
fortunately, you do not have to put any stitches there. That would be tough. But obviously the dorsal dura, you do need
Yes.
the suture.
Thank you.
Yeah. So the next thing we're going to talk, we've talked a lot about intradural extramedullary. Now we're going to spend the rest of the time talking about intramedullary tumors. They're relatively rare. And we're going to go over the different pathologies, the surgical technique. We're going to focus only on intramedullary. We're not going to include any phylum terminale ependymomas. You can see the age range. We're going to focus on what are the pathologies. You can see that the vast majority of them are ependymomas, followed by hemangioblastomas, and then miscellaneous. And actually, astrocytomas are very uncommon in the adult. It's more common in the pediatric population. I do some pediatrics, but not a ton. And that's why you see like almost a 4 or 5 to 1 ratio between ependymomas and astrocytomas. Another pathology we'll talk about is cavernomas. And again, we said hemangioblastomas. Each of them have their special requirements. And in terms of miscellaneous, We've seen lipomas, gangliomas, oligos, melanocytomas, metastases, and occasionally an inflammatory lesion. In terms of presentation, and I think this is critically important, is that these benign tumors, for the most part, almost always present over a protracted period, unless they have hemorrhage. And so if you see someone who comes to your office with an intramedullary lesion that enhances, but has, symptoms over a period of a week and has severe weakness, it's probably not an intramedullary tumor. It's most likely an inflammatory lesion. So most of the benign tumors present over a very long period of time. That's very important to note. In terms of location, it's listed here. Most of them are cervical, followed by thoracic. And again, we've had some at the cervical thoracic junction, but not a ton. In terms of making the diagnosis, it's important to note whether they have a syrinx or not. In general, ependymomas do have syrinxes, astrocytomas don't, and hemangioblastomas often have a syrinx, but if they do have a syrinx, it's usually a focal sort of mural nodule. This is an example of an ependymoma seen on the right. In terms of some of the general concepts for intramedullary tumors, protective positioning, prone, using no paralytics, and typically we use propofol so we can do motor evoked potentials. We usually keep a patient relatively cool. Sometimes steroids, prophylactic antibiotics, very important to keep the MAPS at 85 during surgery. And we typically, in our institution, do SSEPs and MEPs. No, not so much D-wave, but that's another alternative. Intraoperative ultrasound is critical for localization. Operating microscope, ACUSA or Sonopet to help internally debulk, and lasers helpful usually for lipomas. One of the big things about these tumors is trying to figure out where to incise the spinal cord. Obviously, if they come to the surface, it's much more straightforward. But if it's the typical one, you're usually entering the cord through the midline dorsal raphe, and finding that midline dorsal raphe, I would tell you, is critical, and it is what's going to determine how much dorsal column dysfunction the patient has after surgery. Is it a little bit or is it a lot? And it's, as a surgeon, it's your role to try to minimize that morbidity. And by finding the midline dorsal raphe, we're going to go and look at some images in a second. There's a great paper, and I forget the first author's name, talking about how the cord can be rotated because of the tumor, and the midline dorsal raphe may not be exactly where you think it is. It's not necessarily always right in the midline. So this is a picture I like to show because, some people feel like, oh, it's the midline dorsal raphe is where the midline vein is. And that is not true, in the sense that midline vein tends to be very serpiginous. Depending on where you see it, it's not necessarily representative of the midline dorsal raphe. What is representative of the midline dorsal raphe is where the tributaries from that vein enter the spinal cord. And this is you can see here that this is the midline dorsal vein. It is not in the midline, but it's given off a tributary that does pierce the spinal cord and goes into the raphe. And that's where you want to start making your peel incision to be able to split the raphe rather than just, plow through it. If you plow through it, the dorsal column dysfunction will increase, and you will go from just a little bit of numbness to a lot of numbness to actually proprioceptive deficit. So that's why it's so important to spend time at the beginning of the case to figure out where that actually is. In terms of surgical technique, we try to achieve gross total resection if possible, and untether the cord. Rarely do we use a percutaneous lumbar drain. We try to get in ependymomas, gross total resection. Do not chase the rostral and caudal gliotic cyst. Rarely need an expansile duroplasty. Sometimes we do a laminoplasty in young patients. Try to avoid irradiation in ependymomas. This was an example, like I said, of an ependymoma. This is the intraoperative images showing the midline myelotomy and resection of the tumor and not chasing the gliotic cyst. Just to show you an example of a patient who came and saw me with an ependymoma. He was a firefighter. He was relatively young. I told him, very unlikely he'd be climbing ladders after resection of the tumor. He didn't like that response, so he went and got radiation. And you can see the post-radiation changes in the bone, and you can see some response of the tumor with some internal necrosis, but then the patient came back about a year later with progressive quadriparesis and some growth of the tumor and ended up having surgery, which made the radiation obviously made it much more difficult. This is showing the midline myelotomy. This is showing, the veins as they travel within that midline myelotomy and surgical resection. Astrocytomas, less common. Sometimes if they're malignant, you're looking at biopsy as opposed to resection. If you're lucky enough to know that it's glioblastoma beforehand, you can consider a cordectomy, but those are uncommon opportunities. Often, if it's an incomplete resection, we're looking at an expansile duroplasty. There are some tumors that are definitely resectable and others that are very diffuse that are more of a biopsy type approach. And the slide is showing some of those differences. Very hard to do a complete resection of this tumor. That's an astrocytoma shown here. And especially this one, which is very diffuse, this would be more of a biopsy case and a duroplasty. Hemangioblastomas, very vascular, pre-op angio occasionally, embolization occasionally, although it's very hard to embolize these tumors because there's a shared blood supply with the spinal cord. And so the whole point of surgery is to do a en bloc resection of the tumor. They're often peel-based, so they come to the surface. This is in a case of a C2 hemangioblastoma. You can see we did a pre-op angio. It shows that it's very vascular, but not embolizable. This is an intraoperative image. You can see they're very much like AVMs in the sense that there's engorged venous drainage and the arteries, which are much smaller at the periphery. And you can see developing a plane around that hemangioblastoma and resecting it en bloc. And there's the gliotic membrane or gliotic cord around it. This is a exophytic hemangioblastoma from the ventral cord seen here in a patient with hemangioblastoma. Again, one of the keys is bipolaring the surface so that you reduce the blood supply. You cannot go in there with a sonopet and internally debulk it. And that's showing bipolaring it to shrink it and resection of the tumor. Cavernomas, much less common. They can bleed or microhemorrhage. Again, very quickly, an example of a intramedullary cavernoma in a young kid comes to the surface, presents with a Brown-Séquard syndrome after a microhemorrhage. And again, showing intraoperative images, dura open. This is the venous angioma associated with it. The cavernoma comes to the dorsal root entry zone. This is the dorsal rootlets. You can open the pia and resect the tumor, showing the hemosiderin cavity afterwards. And again, complications, and a frank discussion of the anticipated proprioception difficulties that the patient can have is important. Is spending a lot of time with the patient preoperatively and discussing that's very important. Other problems you can get are CSF leak, wound dehiscence, wound infection, motor deficits, sphincter dysfunction, intractable pain, and tethered cord. And just because of the time and my promise to limit the talk to 30 to 45 minutes, I'm just going to sort of say that, you know, not everything that's an abnormality in the cord is actually a tumor. You've got to think of transverse myelitis. You got to think of MS lesions that can look like tumors and enhance. You know, these are a couple of examples of transverse myelitis or MS lesions. And even if you do MRs in patients with stenosis and give GAD, sometimes those can look like tumors as well. The last thing you want to do on your ABNS oral board exam is take out some myelomalacia cord or an MS plaque. That will send you back for another go at the exam in 6 months or a year. So just keep that in the back of your mind when you see patients who present with enhancing lesions of the cord. So that's all I got. Again, Ali, thank you for allowing me to speak. And you know, I'm happy to answer any questions that you have or anyone online has.
Yeah, thank you. Thank you so much, Dr. Levy, for that, you know, sharing a small bit of your vast wealth of knowledge in this area. If anybody has any questions, please feel free to put that in the chat, and we'll relay it over to Dr. Levy. I did have one question regarding the patients that you see with, say, intramedullary lesions. You suspect they're tumors, possibly low-grade astrocytoma or even ependymoma, and they're presenting with minimal symptoms. And you know, it's hard to, you know, minimal, right? Let's define that, but let's just say minimal neurology. They clearly have a lesion. When do you pull the trigger on saying, you know what, yes, we have to biopsy or we have to explore it versus watching it? So your indications for intramedullary surgery in a patient with few symptoms. That I'm interested in your answer to that.
Yeah, I mean, it's easy if it's no symptoms and it's incidental, because you'll see a lot of patients like that. And that's an easy decision. That decision is wait and see how you do and do repeat MRs every year and come back and see me. If they have minimal symptoms, a lot, I think, depends on how big the lesion is, how expanded is the cord, and how old are they. I mean, if they're 75 and they're already, you know, using a cane to get around because they're just 75 and have bad hips, you know, you're probably, and it's a deep tumor, and you know, you're probably going to not want to remove that and just say, let's wait, because they are slow growing. But if they're young and you know, there's a lot of you know, enhancement and the cyst is big, you know, that probably more likely to end up needing surgery. But you know, anytime you propose surgery, you want your patients to be really asking for it rather than selling it.
Yeah, that's fair. That's fair. All right, wonderful. Well, I know it's almost 7 p.m. Eastern time zone. So thank you, Dr. Levy, again. Absolutely great presentation. This will be shared online, of course. And again, it's an honor to have you with us.
Thank you for the invitation. Have a great evening, everybody.
Thank you. We'll see everybody next week.